There's two FDA-approved PCSK9 monoclonal antibodies, and evolocumab and alirocumab, and they have the same package labeling essentially. People with heterozygous familial hypercholesterolemia, or people with clinical cardiovascular disease who require additional LDL lowering. So they kind of left it vague. what does require additional LDL lowering? They need to be on maximal statin therapy, and the evolocumab has another indication for treating people with homozygous FH, which is 1 in a million. It's really rare. The FDA also pointed out that there was no cardiovascular outcomes data yet available. So that's the label. So where are we at? It's approved for LDL lowering. And I think, if you target people who have heterozygous familial hypercholesterolemia and focus on that group and just treat their LDL down to a level of 100. My last set of comments, these people have had a lifetime since birth of exposure to really high cholesterol levels. They have a huge advanced accelerated plaque. You think, and their LDL levels are really high. Give them a statin, give them ezetimibe. And many will actually get LDLs down to 100 on that, but those with the, kind of started a little higher, who have statin intolerance, a PCSK9 inhibitor is just a miracle drug, really. I mean, we're getting LDLs routinely down below 70 in these patients, which, if you think what's happening with regression in their artery, I mean, it's, we're getting really excited about it. In terms of the larger picture of using in other patients, clearly, if somebody's got heart disease, diabetes, a high LDL, they're statin intolerant, they would be reasonable to treat. I think the insurance companies are not really approving too many of those. They're approving and that's probably appropriate in the absence of outcomes data. There are 4 cardiovascular outcomes trials going on. We expect the first to start being reported hopefully by the end of this year and then through 2017, so we'll have a whole bunch of evidence. What we're going to do with it, I don't know, because these drugs are, their list price is $14,000 a year, so which is, usually a on-patent it's like $3,500 a year or something like that. So I mean, quite a bit more than people were, certainly those of us in the field were expecting, and unfortunately, it's really, as a consequence, limited its sales. We were talking to the marketing people, kind of helping them think about where to position this drug and address unmet need. I said, well, okay, you can sell a whole lot of drug with a little overhead, or you can sell not very much drug with a really big overhead. And you're going to make money with strategy A and strategy B, and I think they picked strategy B. I'm not really sure why, but we'll see how it all works out in the end. It's like any new drug, the first couple just try to ream you, and by the time you get to 3 and 4, the price starts coming down. These are also high-tech antibodies, so they do cost more than small molecules, and they should be more expensive. I don't think they need to be as expensive as they're charging. There are other people working on what we call small molecules, so pills you could take to block PCSK9, like intracellular, synthesis, pathways and things like that, to get away from the injections of an antibody. But again, we always have a bunch of drugs fail, even though it's the same mechanism. They may fail for safety because, again, it's they're affecting other pathways and things like that. So, there's an injectable kind of a synthesis inhibitor. It's a mRNA analog, but anyway, it's going to block synthesis. It seems to work for 6 months. I'm sure you can have 2 $6,000 injections, or so it's kind of frustrating because we have all these patients who it would be so fantastic to get their LDLs down. I mean, because basically, the lower you get the LDL, at least with statins or ezetimibe, the lower you get, more you reduce risks. Well, there was one more trial, late-breaking clinical trial today called Accelerate, and this was a drug with a novel mechanism. It's so PCSK9 inhibitors block the LDL receptors from being degraded, and so that actually the statins and ezetimibe, actually their effect is mediated through the LDL receptor. The LDL receptor takes the bad cholesterol or LDL out of the blood, so having lots of LDL receptors is a really good idea. So this, as we've investigated other mechanisms, so the CETP inhibitor, it's a complicated metabolic pathway, but it raised HDL 100%, doubled HDL levels, lowered LDL another 35%, and they stopped the trial for futility because there was no reduction in events with it. And I mean, they were directly superimposable during, I think the average follow-up was like 2 years, but some were as long as 4 years. And so they stopped it for futility. So how you matter LDL seems to make a difference. I think we've kind of been learning that with niacin and fibrates and different things. So I think that was quite interesting. So lower might be better for LDL, and it matters how you get there and in whom. So I think all the data I like to point out does support our guidelines, the 2013 ACC-AHA guideline, where we focused on intensifying statin therapy in the appropriate patients, and then kind of carefully considering who we might add a non-statin to for further LDL lowering. So thank goodness we were right. But I think the evidence really supports taking a little more cautious approach to new drugs that lower biomarkers.